ومعاكم هنا النهاردة من مؤتمر دايابيتس يوكي، مؤتمر الجمعية البريطانية للسكر اللي معمول السنة دي في مدينة ليفربول. قابلت أستاذي بروفيسور سليمان تسفاي، أستاذ السكر والتهاب الأعصاب السكري في جامعة شيفيلد في إنجلترا. Good morning, Professor. Would you please introduce yourself for the people of Egypt?
My name is Solomon Tesfaye. I'm professor of diabetes medicine at the University of Sheffield. And my area of interest is particularly the pathophysiology, the treatment of diabetic neuropathy.
Okay, Professor, it's a great honor to be with you today. How long have we known each other?
Oh, over 10 years, I'm sure.
Anyway, so recently I have been lucky enough to see the interview, or I don't know how you call it, the video at the Parliament. You were at the British Parliament discussing something.
Yeah. Yes. Well, thank you for raising that. So I was invited to the House of Commons Health Select Committee to give evidence. So in the UK, when there is new innovation, new treatments, scientists can be invited to present their work or their data to see if there are better ways of treatment that can be commissioned by the Department of Health. And so that was the reason for going to the Commons Health Select Committee.
Okay, and what was it which you presented there?
So what I presented is the Sheffield one-stop shop. So what we did in Sheffield about 10 years ago was that instead of having 6 appointments or more for us to do all the health checks, the 9 health checks, all people with diabetes should have annually, to just one visit where they have everything done, like a car MOT test in the UK. Everything is checked and you're not allowed to drive that car unless it's roadworthy. So the brakes are faulty, they have to be fixed before you can drive the car. And that's an analogy. So all people with diabetes don't need to have 6-7 appointments a year to have blood pressure check one day, A1C check another day, and so on. Foot check, etc. Eye check. Yeah.
Please tell me the 9 checks. What are
they? The 9 health checks are the A1C test, which is the HbA1c, a measure of long-term blood glucose control.
In Arabic, السكر التراكمي.
Okay. And the second is blood pressure. Blood pressure. Number 3 is body mass index, we call it, to check of the body weight and height, and to
it's a measure of obesity.
Okay, number 3. Number 4 is kidney check, and there are 2 kidney checks. One is microalbuminuria, urine, ACR, albumin to creatinine ratio of the urine, and also the second is the EGFR. That makes it 5. And then we do lipid testing, so check for cholesterol, HDL, LDL cholesterol, and then we also do the foot check. Now the foot check is to check for foot pulses, but also to check for neuropathy. So that's a foot check. And then on top of that, we do an eye check and smoking review. So this makes 9 healthcare checks every year for all people with diabetes.
Okay, I just wanted to ask on a few points there. First of all, how do you check for the vessels of the foot?
So in the UK, there are many, many ways of doing these, and there is a big controversy as which is the best. I think in general, the easiest is to check for foot pulses. So as a trained doctor, or even nurses can be trained, or podiatrists can be trained to check for the dorsalis pedis pulse.
Which is the vessel, that's an artery
on the
surface of the foot.
Yeah.
Okay.
And posterior tibial is on the side. It's on the ankle, on the medial malleolus.
It's in the inner side, just under the bone.
Under the bone, yeah.
Yes.
So we check for those routinely, and if they are present, and you've got to be careful because sometimes when you move your foot You might think you're feeling it, but you may not feel it actually. You need to check it to check that it tick, tick, tick. It's actually you've
needs
caught
a
the
little
pulse.
experience.
It needs experience, absolutely. So we check for that. But where it's absent, there is controversy, which is the best. Do we do toe pressure, which we can do? Do you do ankle brachial index? Do you do duplex ultrasound? Do you do direct imaging of the artery using magnetic resonance
or CT
angiography?
angiography?
Yeah. So there is big controversy. Some people are saying none of these are good enough, apart from of course, the angiography because of calcification in the diabetic foot. But that's a discussion for another time.
Okay. You don't do handheld Doppler back?
Handheld Dopplers also are not very good. Some of they give you false positive, false negatives.
Totally depends on whoever's doing it.
Yeah, who's doing it. So there is a recent paper that's been published, which you can download and see, comparing all these different methods. Nobody would publish it because he said that they're all not very good. And obviously, there's a lot of money involved in these and how to do it. So,
so it's basically a question of money.
It is, and it depends how you do it, and like operator dependency. But I think overall, what we do in Sheffield is we do just foot pulses with hand and handheld Dopplers. In our hands, they seem to be good. If they are showing that diminished flow, and clinically it looks ischemic, then we go immediately to MR, magnetic resonance arteriography, angiogram done, and then referred to the vascular surgeon immediately.
Okay, what we do back home, my clinic, for everyone, we check the pulses manually, just like you do. We do handheld Doppler, and we do ABI, automated ABI for everyone.
Yeah.
Okay.
So that's some people are saying it's not good enough, but
okay,
but you need to read the new paper. I will send you.
I'm sure. Okay, ABI is 60-70% sensitive.
Yeah.
Okay, but the thing is, when you're combining several modalities,
we need to look at the evidence. But ultimately, the key question is early intervention.
Absolutely.
Do not delay until a wound or is too advanced. Intervene early.
Speaking of, in your talk at the Parliament, you said a phrase which was completely shocking for me about eye screening in the UK.
Yeah. Okay. So let me talk. So the biggest problem we have in the UK at the moment is that uptake of these 8 care processes is only 50%, whereas uptake of eye screening is 85%. Big difference. People are scared of going blind. Why if you ask that person with diabetes, which is the worst complication you can have, even from dialysis, even from from losing a leg, people are scared of going blind. I don't know, because I think when you don't have a vision,
all of them are terrible.
All of them are terrible, but people attend the eye screening program because it's an independently funded program, a separate program. So it's organized directly from the government. They put a lot of money into these. It's done with dilated pupils until recently, but now you don't need to dilate the pupils.
You do it with the new fundus camera technology. Yes,
there's a new technology where you press your eyes. I had it myself only 2 weeks ago, and even with undilated people, you get beautiful wide angle image. So you don't need eye drops. You can't drive and all that problem. So what I did then was to do a separate approach, because the people that come to foot clinic, they were coming with advanced disease. Once they come to my clinic with the foot clinic, we have 20 clinics in Sheffield. And it's not a mark of success, it's a mark of failure.
I totally agree.
Because once they come to the foot clinic, they die. 50% will die within 5 years.
I totally agree.
It is worse than quite a lot of cancers. So I said to myself, they're coming because they have poor control. leading to neuropathy, to complications. Why don't we catch them early? The best way to catch them is from diagnosis. Type 2 diabetes, we have to have early management of early complications. Early management, early complications. So we don't use monofilament. The waste of time. You diagnose the condition very late. We use point-of-care devices, DPN check and pseudo-scan combination to assess for early neuropathy. If you use monofilament, you diagnose neuropathy in 14%.
It's pretty
But if you use the DPN check, you diagnose neuropathy in 51%. So you diagnose the condition.
What about pseudoscan?
Pseudoscan, we get 38%.
Okay.
Now, some people don't like pseudoscan. I have to mention these because I think, but in our hands, the way we did it in Sheffield, it seems to be a very good technology. But there are people who are critical of pseudoscan, as I need to mention.
Well, and if I may say something in this issue, it's basically like a car. You can have a wonderful Ferrari. No one can say anything bad about a Ferrari. But if someone doesn't know how to drive, it's a horrible car. He will probably die in it.
Yeah,
okay, so it's the same thing.
It's the way you apply, and certainly Sheffield, because we test.
You are experts.
We
in
are
this,
experts.
yes?
We test all these equipments for companies, and they come to Sheffield first. So we use these. So the patient comes to have eye screening done because we send them a letter. You're coming for eye screening, but instead of just looking at your eye, we're going to check everything. It will take 35 minutes. Now that there is no dilated pupil required, it's going to be 30 minutes. So literally, they come. You check their eyes, 5 minutes, gone. After 5 minutes, what do? You just do the foot check, which takes the longest, and we use DPN check and pseudoscan and the DN4 questionnaire. We do those three, it takes 10 minutes, okay? And then after that, you do all the blood tests and the body mass index and blood pressure. And by the time the patient leaves in 30 minutes, they have everything done. It avoids 6 visits to see their GP. So we tested these one-stop shop, the Sheffield one-stop shop. It's being piloted now in the Philippines, in many countries. And this one-stop shop then worked really well, and it was cheap. Instead of individual GPs trying to do everything, the patients are referred to a hub where they have everything done and by a trained professional who has a critical mass, because they do this all the time. They become good at it. Instead of individual 200 practices trying to do everything, if you send, with a lot of patients, and then once we've done everything, the results come, and the results are immediately given to the patient. The patient is given their risk score, and they become drivers of their own treatment. We tell them your cholesterol is high, your blood pressure is high, your glucose control is high. So they know what needs doing. And they are referred quickly. We act quickly. We engage the patients because everybody can be normalized now with type 2 diabetes. The Oceanic trial, which is taking place in Sheffield, is looking whether improved metabolic control and weight control can reverse diabetic neuropathy. It's the first detailed study. We're doing skin biopsy, we're doing serial amplitude, we're doing
all the complicated
tests on and we have 60 patients in the intervention arm, and these patients have intensified treatment. So we use technology. Everybody is fitted with Freestyle Libre. Monitor their blood glucose control, and it's also a good educational tool. They can see the food spikes when they eat. It changes to behavior change. And we also use the weight loss jabs, like Mounjaro, Ozempic are used widely. Almost all of them are on it now. Almost everybody.
They are
the
miracle
intervention
drugs.
now. And these are people with early neuropathy, and they have poor control. We choose deliberately people with poor control. And lo and behold, 95% are normalized within 6 weeks. So there is something we can do. Our new drugs are amazing. They improve control very quickly and without inducing hypoglycemia. And so these has led Sheffield for us to say, why are we not diagnosing the condition early and managing them en masse? So I presented our model of care in Sheffield, delivered in hubs, big hubs. So many GPs refer their patients to these hubs, and everything is done for these patients. Treatment started early, very successful. It increased uptake from 50% national average to 85%. And the House of Commons Select Committee looked at all the evidence that I provided. I sent them also our papers, and then they responded with a letter to me. And I'm delighted to inform the Egyptian public that the Leila Moran, who's the chair of the Commons Health Select Committee, she MP, Member of Parliament, honorable member, she wrote to me and said, they will recommend this model of care to be funded independently by the Department.
Congratulations.
So that's the only way to improve outcomes. If we tinker here and there, we give, improve these bits, you have to have a fundamental change, because the biggest lesson I learned is that when we introduced eye screening 15 years ago, no, actually longer, 20 years ago, everybody had to have dilated pupil fundoscopy with a camera, early referral, early treatment, game changer.
Yes.
Retinal. The UK is the only country in the world where retinopathy is not the commonest cause of working age blindness. In any other country, the commonest cause of blindness in working age
definitely
is
diabetes.
The only countries, this is because it was done properly, it was properly funded. What I'm trying, I hope I convinced the government of the UK, is that without properly funded service, properly good process, foolproof process, digital technology. So, we need to prioritize. If somebody has everything normal, there's no need to see them the following year. Day once he's normal, If, on the other hand, if you have early changes, you have to be seen quickly until everything is normalized, like in the Oceanic trial. So this is cost effective in the long run, because the cost of the diabetic foot in the UK is over £1 billion, English pounds.
I think it's
more
similar
than the combined costs of prostate, breast, and colorectal cancer combined. Very expensive, because patients spend a lot of time in hospital. They need ulcer healing. A lot of the money is going on hospital admission, ulcer healing. 10% is only put in for prevention. But, like you and I, if we're healthy, if we live a healthy lifestyle, we'll live long, A, and B, you avoid visiting hospitals. It's simple. So we've got to emphasize the government 10-year plan, which is sickness to prevention, from hospital to community, and for analog to digital. The digital is going to help us to stratify patients that need to be seen quickly, and actually delay seeing the patients that have everything normal. We stratify to target the people that need the treatment. And I think if this modality is introduced to the NHS, and hopefully not soon, I'm hopeful it will be a game changer.
Okay. I have just one question here. This morning in Professor Kunti's lecture, he mentioned something which sounded very familiar to me. Okay, he put the slide on where my father died of diabetes, my mother has diabetes, I'm second on the line. Okay, and the other guy saying, I don't believe I have this. I'm depending on fate. I'm depending on God to decide what will happen to me, etc. I'm a believer. It's not an atheist comment, but the word or the idea of prevention back home in my country is pretty much disliked.
Inshallah.
Inshallah. Okay.
Yes. I am very against that. So recently, in the UK, ethnic minority groups have worse outcomes. And because they, at all levels, you're having screening, they don't attend, they don't have treatment that they need. And so this is called health inequality. This health inequality, and Professor Kamlesh Kunti gave a beautiful lecture today.
Yes.
And so we need, so what we did recently in Sheffield, in our option DM trial, only 3% minority ethnic groups were represented in the trial.
Which is very bad.
Which is really bad, because the population in the UK, around 20% is ethnic minority group. So what we did was we went to mosque, Medina Mosque, it's called in Sheffield, the biggest mosque in Sheffield. I spoke to the imam, and the imam also from Redford, the top imam also came. And we did a session all day. Following that, we recruited 20% of the oceanic trial is now people with ethnic minority groups. We increased.
This is a great achievement.
Because what the imam said is, look, Allah wants you to look after yourself, to improve your outcomes. This thing, what will happen is not right. But he was really forceful. We need to change our lifestyle. We need to exercise more. We need to eat less. We also need to take our medications, look out ourselves. And this is what Allah wants, is what he said. And I think after that, everybody came and registered to participate in our research trial.
That's really good. That's a real achievement. Anyway, I am very happy I have met you. We haven't seen each other for 6 months now or something? Yes.
We'll see each other in Neurodip.
Yes.
Hany, well done with all the work that you do in Egypt.
Thank you so much.
I think last time I was in Alexandria at the endocrine meeting, which was really fantastic. And
I didn't
Professor
Noha Gaber. I mean, yes, I know her. I know her very well. Yes,
fantastic.
She's a friend. Yes.
She is really good, and she invited me. And I also went to visit the new pyramids, the museum.
Oh.
I think is the best museum in the world. So congratulations, fantastic museum.
Thank you so much, and I'm happy to see you, sir. And until we meet again, have fun.